So in part one of our lesson on upper respiratory tract infections, we talk about the different commonly encountered infections such as acute bacterial pharyngitis, pertussis, epiglottitis, and the less commonly encountered diphtheria. So in part two, we will review the identification of the common isolates that cause these different infections. So let us review the laboratory diagnosis of infectious agents involved in the upper respiratory tract infections that we previously talked about. Now, because the upper respiratory tract is involved, samples will come from upper respiratory tract secretions. Samples will be collected from either the throat, the pharynx and tonsils, or the nasopharynx. Unlike samples from cutaneous infections, direct smear of upper respiratory tract infections is of little value, except for the diagnosis of Vincent's angina. Remember, where the direct gram-stain smear is the only method to make a diagnosis. You have to look for the spirochete Borrelia and the fusiform Fusobacterium necrophorum or other Fusobacteria together to be able to make the diagnosis. And that is the only time that the direct gram-stain smear from an upper respiratory secretion will be of value. Now, to differentiate bacterial pharyngitis due to streptococci from viral origin, a throat culture is therefore performed. So we know that group A streptococci or Streptococcus pyogenes are catalase negative. They're gram-positive cocci that occur in chains. Streptococcus pyogenes produces beta hemolysis on blood agar. This is described, as you can see in this particular image here on the right, upper right, clear white zone of hemolysis on the sheep blood agar plate. Beta hemolytic streptococci will show clear zone of white complete hemolysis. So if you look at the colonies closely, you'll find that the colony is particularly small compared to the zone of hemolysis. Now observe the second throat culture shown here below. Do you see any beta hemolytic colonies? Because we're only and most interested in finding beta hemolytic group A streptococci on cultures taken from the throat to rule out or rule in to diagnose acute bacterial pharyngitis. When there is a beta hemolytic colony found, then we will then identify that beta hemolytic colony. However, when there are no beta hemolytic colonies found on the throat culture, as you see here in the lower left image, then this can be interpreted as a normal respiratory flora isolated, and there are no beta hemolytic streptococci present, and no further workup is then necessary. To identify group A streptococci, we use the A disc or the basitracin disc, where group A streptococci is susceptible, and it will form a zone of inhibition, as you see here. We only should perform this A disc susceptibilities on isolated colonies. Direct antigen test may also be performed, as well as a PYR, as you can see here. So now let's take a look at pertussis and how pertussis is diagnosed in the laboratory. The diagnosis of pertussis is based on a characteristic clinical history, that is coughing for more than 2 weeks with whooping sound, paroxysms, or post-tussive vomiting, and that is when the child vomits after this continuous coughing, as well as a variety of laboratory tests such as culture, PCR, direct fluorescent antibody or DFA, as well as serology. So here you can see a schematic diagram of how isolation and cultivation of Bordetella pertussis may be done. So, because culture is considered as the gold standard laboratory test and is the most specific of the laboratory tests for pertussis, what we need are really good, well-collected samples, and the recommended way to obtain samples is using 2 paranasal or nasopharyngeal swabs. One is for direct fluorescent antibody testing, and the other one for culture. Bordetella pertussis is very fastidious, as we have already learned, and the growth requirements to isolate and recover this organism is particularly difficult. The yield of culture can be affected by specimen collection, transportation, and isolation techniques. So specimens from the posterior nasopharynx, as I mentioned just earlier, not the throat, should be obtained using dacron or calcium alginate, not cotton swabs. We already learned that from Micro 1. Now, DFA testing of the nasopharyngeal specimen may be useful as a rapid screening test for pertussis. The use of monoclonal DFA tests has improved the specificity, but remember that DFA still has a low sensitivity and should not be relied upon and should not be a standalone test as a criterion for laboratory confirmation. Since culture has excellent specificity, it is particularly useful for confirming pertussis diagnosis when an outbreak is suspected. Many other respiratory pathogens have similar clinical symptoms to pertussis, and co-infections sometimes do occur. So obtaining isolates from culture allows for strain identification and antimicrobial resistance testing. Identifying which strains of pertussis are, or which strains of the Bordetella pertussis are causing disease is also public health importance. However, cultures are variably positive and although yields about 30 to 50% and may take as long as 2 weeks, so results may be too late for clinical usefulness. Cultures are less likely to be positive if performed later in the course of illness. As you can see here, that culture is best done at the onset of the cough. Oh, excuse me. No, I don't have pertussis. Just a frog in my throat. So, if cultures is performed later in the course of the illness, that is more than 2 weeks after the cough onset, or on specimens from persons who have received antibiotics or have been vaccinated, then the sensitivity of the culture is lessened or decreased, and the risk of false negatives increases. Because of the increased sensitivity and faster reporting of results of PCR, many laboratories are now using this method. And however, PCR should be used in addition to and not as a replacement for culture. PCR is less affected by prior antibiotic therapy, since the organism does not need to be viable to be positive by PCR. Nevertheless, continued use of culture is essential for the confirmation of PCR results.